sort of setting in which it finds itself. You not only need a well-filled euvolemic patient, but one that's got a recent map and optimum delivery to the graft to try and optimize outcomes. We've all had experience of the surgeon that will keep driving fluid for as long as they can over any other intervention, but hypovolemia increasingly looks like it could cause both patient and graft harm. And there is increasing evidence that I'll go through later that if you give too much fluid and hemodilute your patients such that they need transfusion, that might increase their risk of long-term graft rejection. I was part of a team with Claire Mulcaine and a few others in the department that did a survey of national practice a couple of years ago. And considering there's not that many centres that do renal transplantation, you'd expect a fair degree of homogeneity across the country on what we do. But what was remarkable was the variation in practice that we saw. Despite the fact there's now good evidence that normal saline, not just in general surgery, but specifically in renal transplant, causes quite a lot of organ harm, it's remarkable that over a third of centres still use normal saline as their primary fluid. Only just over a quarter of centres were using any kind of cardiac output monitoring, and many more than that were still using a CVP target to try and promote euvolemia. And I think most people would accept now that CVP probably isn't a useful marker of volemic status until you get to very high or very low CVPs. What was even more interesting was, although most centres said that they would target a blood pressure, you can see in this table at the bottom that the range and departmental guidelines on what people would try and target. I think that says a lot in itself about the sort of the lack of evidence base about what we're doing for these patients. So what do we want to do? So, we sort of took together all the information we could find on these patients and kind of the basic premise of using goal-directed hemodynamic therapy in complex surgery. We decided we needed a non-invasive approach. We don't want to instrument the arterial tree if we can avoid it, because the arteries might be needed for future fistulae. We wanted beat-to-beat blood pressure and other information, as these patients probably have hypotension around induction and around clamp release and the like, where we're not picking it up because you've got the dead space between Dynamat readings. And the Clearsight device kind of provides us with all of that, as well as a marker of cardiac preload, which is the stroke volume variation, as well as having a good adverse event profile. And we wanted to essentially use the standard principles of protocolized therapy to individualize fluid and other therapy to try and minimize complications, as well as not only promote euvolemia, but a good mean arterial pressure. It was obviously only adult patients done here. We took any kind of graft donation, and before starting, we had a kind of agreed data set between all the different stakeholders. So there was an original cohort that was audited on our previous standard of care that used a fixed rate fluid infusion. And then we had a more recent cohort that finished early last year that used the protocol. So this is the protocol itself. You can see the device that's put on the finger part of the device on the top right. And so in terms of running through the protocol then, so you give a 500 ml bolus at the start. That's designed to offset starvation or recent hemodialysis to try and bring them towards euvolemia. Then you do recurrent cycles of hemodynamic appraisal. So we set the SVV target at 10%, which is probably a little generous, but that's to try and promote fluid over any other intervention. And if it looks like they are underfilled, so the stroke volume variation is 10% or above, then we would suggest a fluid bolus, and that's on the background of some Hemosol, kind of a low fixed rate maintenance. Where the patient's euvolemic and then normotensive, so we've gone for a map of 75, as I said, this is quite a hemodynamically sensitive cohort, then we would just say, keep paying attention and see what happens. If they are euvolemic but hypotensive, then we would sort of suggest use of ephedrine titrated to effect, and then a phenylephrine infusion over metaraminal to try and minimize any kind of alpine anesthesia. So in terms of outcomes, we had 43 patients in the standard group and 28 in the Clearsight group. You can see there were no differences in baseline demographics. Importantly, in the Clearsight group, more patients were on dialysis, more patients had lower hemoglobins, and they had higher creatinines. And you can see there was a reasonably equivalent spread in terms of risk factors for primary non-graft function and the like. In terms of outcomes then, so on the left you can see there was a lot less fluid given to the Clearsight cohort. We went down from just under 4 litres to just under 2.5 litres. If you correct that for case duration and patient weight, that significance remains. And on the right, you can see that there was a non-significant trend towards a reduction in the use of vasopressors, a significant reduction in the use of normal saline, probably also mostly for a reduction in the use of gelfusin, and a trend towards a reduction in the need for intraoperative transfusion. Post-operatively, so starting on the left, the incidence of pulmonary edema essentially vanished, went from about 18% to 0%. The trend towards a reduction in blood transfusion persisted, so about 19% down to 11%. That's up to 72 hours. And then significantly, we saw that the rates of post-operative ileus and early mobilization both improved significantly, which was really quite pleasing to see. Graft outcomes. So obviously the surgeons are quite nervous about this, as it's quite a change from our previous practice. But what we saw was there was no change in primary non-function, delayed graft function, or the time to resumption and function, or the need for post-operative dialysis. And when we tracked creatinine changes over 90 days post-operatively, you can see there was no difference in outcomes. In conclusion, so obviously we gave these patients a lot less fluid, but hopefully it was better titrated, and that led to improved patient outcomes. They weighed about 4.5 kilos less if they had the Clearsight protocol than if they were on the previous standard of care. And obviously limitations, because it's a small study design and retrospective prospective, but evidence that we might be able to improve outcomes and hopefully save costs as well. Obviously a lot of people involved in putting this together I'd like to thank. And then we'll quickly, if there's any questions now, otherwise we'll move on to just demonstrating the kit. So the question there was how much faster are they mobilizing? So the definition of early mobilization was out of bed within the first 2 post-operative days. And I think, I can't remember the exact numbers, was about 70% to about 90-something%. There wasn't a reduction in length of stay that was significant, but I think we've got quite small cohorts to see that kind of detail. So I think, you know, hopefully with a large cohort, we'll see that kind of outcome benefit. So we'll move on. Felicity's going to show the kit now. Just bear with us. I think we might need to screen a bit closer. Can you see the screen?
How is that?
You can't really see what's on the screen.
No. Fine.
Can I angle it? Does that make a difference?
All I could do would be
So right in the middle, it's all white.
Right. Oh, there we go. That might help. Yeah. Is that better? Yeah. Okay. Hi there. So my name is Felicity. I'm here from Edwards Life Sciences. So I'm going to just talk you through setting up the device. So to put the finger cuff on, you need to measure up. So one of the 3 middle fingers, and it's going to sit on the middle of the finger. So between the 2 knuckles here. So it's going to sit in the fleshy part in the middle here. There are, in the basket, you'll find some tape measures, so kind of like ring sizing. And by putting that around the finger, it's then going to indicate which color finger cuff they need. And in the basket on the bottom of the monitor, there will be hopefully one of each size that you can hopefully see here. The device then needs to be wrapped from underneath. So you're going to unvelcro the cuff. And hopefully, if you can see that there, the finger just lies in the middle between the 2 kind of tram lines that you can see, hopefully there. And then you wrap accordingly. So I'll just put that on myself. So it should hopefully look like that. So you can see the picture of the finger on the device on the top like that. This then plugs into the cuff controller that's going to sit on the forearm. So this device just has a little Velcro strap on it to hold it onto the patient's arm. So it's close enough for the connection to be made into the top there, and it will go into the port that says cuff 1. So I can put that on myself quickly. bear with me one sec. Take that out. So the device should then sit on the forearm kind of like that, with the cuff like that. And then when you come to the monitor, you need to put some patient demographics in. So hopefully you can see that relatively clearly there. Is that still quite clear? Perfect. And then I'm just going to put this into, you don't need to do this. This is just so I can show you a bit of kind of fake sort of generated data. So then the device is going to ask you, well, what position are you in? So the option you need to go for is this first one here, which says patient sedated and stationary. So highlight that and then press enter. And then in 1 second, it's then going to ask you, well, what position is the patient's arm in relation to the table of where they're lying? So you can then pick this up here. Oh, you could pick this up here so that you can then reposition the arm according to where the patient is, just so it gets that level for the duration of the procedure. Once you've done that, you can then just press enter. It's going to ask you to just verify that and then hit start monitoring. Then you need to press this icon here to inflate the cuff and get the cuff going, and just hit start monitoring there. And then we should start to get some numbers coming up. I'll just take us to a different screen. So if ever you want to change your screens, it's this icon here. So for instance, if I take us over to this one, and then in a second, you'll start to see your arterial trace at the top, and then the associated pressures. And then you're going to get your flow parameters across the bottom there. Is that one of the main screens that you would normally use? Yeah, perfect. Yes. Okay, so I think this is one of the main screens, but if ever you need to change this, by going into the screens option there, you can then sort of have a little play around with that. If ever you need to change any of your parameters, just tap on it there, and that's to adjust your alarm limits as well. If I go into a different one here, so for instance, if we go into this screen here, and then you can change any of your numbers just by tapping on the letters themselves, and then it gives you the option to make any changes there. The key thing with the device is, obviously, if you've got yourself a good trace across the top, then that means that you're getting a good signal from the finger. And also you'll see when demo disappears, there's this little interval here. So there's a little green step and a number. And that number is basically telling you the kind of calibration interval. So as long as that step appears green when it comes up again, and that number is above 30, then you've got yourself a good strong signal from the finger cuff itself. And from my point of view, I think that's pretty much everything. The key thing with this device is, though, that every couple of hours you will see the numbers disappear for 5 minutes. It's just resting the finger and then it will automatically restart. So that's about it.
Thank you.
Let's keep going with this.
Brilliant, thanks Felicity. Any questions about any of that? Download the data?
Yeah.
Oh, yes. So I think there should be a USB at the back normally.
But that's the bit I don't know how to do.
Okay, do you want to demonstrate quickly?
The guidance on this, I need to just double check the settings, so I'm not going to demo it just
Fine.
now. But
we'll get back to you on that bit. So Felicity's kindly going to run some training in the seminar room for the next hour or so. So once we've all got started, if people would just intermittently filter in, and then we'll do some hands-on teaching on it as well. Thank you.